to encourage this content to be infused into our other means, such as a professional certification, to help augment this knowledge base for social workers. And we're focused on Florida. I mean, obviously, this is a nationwide problem. This is something that is not unique to Florida. So I'm not calling out Florida as having a particularly bad in College of Medicine, College of Nursing, and other health professions, that we hope that they will also be able to develop curriculum to highlight the necessity for health professions to become more cognizant and more expert in the delivery of substance use disorder. We have 15 modules that are being developed. Those 15 modules, again, we are hoping other colleges, such as the College of Medicine, will be able to take out of those modules what they believe could be helpful for their students. We have one module completed, which is module 2, and it is What is Addiction? And it is an extremely extensive, detailed module. This could be very helpful for a College of Medicine. Our goals are for today. We do have some presentations that we hope you find interesting. We tried to tailor it to not only what some of our FSU faculty are expert in, but what we believe, the consortium believes, are important topics to highlight. We will be doing having our keynote presentation from Captain King, and then we will do a sort of a rapid fire session so that you're challenged and you're just getting a little bit of the terms of these areas of what we're doing here at FSU. We also are going to be highlighting the substance use disorder issues relative to young adults. We are on a college campus. We believe that this is a priority population, and then we want to be sure to highlight those populations. The end of work of the consortium members. They are meeting today for the first time as a consortium. We've met twice by video conference call, but we will be facilitating a discussion of that group in terms of the development of the curriculum and the discussion of learning strategies. We will have a period of time for Q&A. So if this is something that you would like to stay for, we will have an opportunity for you to provide input to us as the consortium developing this curriculum. We value the opinion of community providers because you are the ones that are providing the services and you are the ones that are hiring our social workers. So with that, I again welcome you to our first annual symposium of the consortium, and I'm going to introduce now, my honor is to introduce Captain Michael King, who is the Regional 4 Director for SAMHSA, the Substance Abuse Mental Health Administration. And Region 4 does include Florida, and we're so glad that you have come. And I'm going to get your PowerPoint up. And putting me in charge of the technology is maybe not the wisest.
All right, gang. So we have a lot to talk about in a very little bit of time, and I know I've been told I'm going to get the hook. So my name is Michael King. I'm going to share with you 3 keys to success in public health today. And the first key to success is knowing who you are and why you're doing what you're doing. So I'm going to share some of the data that SAMHSA has collected. The second key to success is helping other people. or helping others in general. So I'm going to share with you some of the ways that SAMHSA is working with its partners at a sort of 10,000-foot policy level, and some of our HHS partners. And then the third key to success is helping yourself. And we're going to do an exercise today, most of this morning, that will help you be a better public health professional in whatever role you play. So you have handouts. You're going to need those handouts. If you don't have one, there's some extra ones here. You're going to need a pen. You may want your phone to take pictures of the slides so you don't have to wait around to access some of these resources that I'm going to share. So make sure you have your phone handy, your handout handy, your pen handy, and we're ready to go. So this is the mission of SAMHSA, the Substance Abuse and Mental Health Service Administration. This is just a fancy way of saying saving lives. I believe that we all share this mission. So this is not just SAMHSA's mission, this is your mission too. This is my cohort of regional administrators. Many people don't know that SAMHSA has 10 people out in the regions. We have 10 HHS regions. There are 10 of us. There I am down in the corner. Look how nice I am. Look in the, right? And some of these other pictures are really good too. You know who is in your region. The neat thing is SAMHSA is a young agency. It was founded in 1992 through a reorganization of some other agencies. And we also have fewer than 600 people typically in any given year. But they are all in DC. I am here in Region 4. I am your contact in Region 4 for anything to do with SAMHSA. I'm your advocate. I work for you guys. I try to remind people that because many folks think they need to call DC to try to get some information from SAMHSA. And sometimes that's the most appropriate thing. But if you have an issue you can't resolve, or if you just want to talk to somebody about SAMHSA stuff, call me or email me. And it turns out the most difficult part of emailing me is spelling SAMHSA. It's true. That's why there's a fill in the blank on your handout. And at this point, we are going to rehearse how to do SAMHSA, and we're going to use the SAMHSA cheer. And the reason we're going to do the SAMHSA cheer is because sitting is the new smoking, and most of you are going to be sitting for a lot of today. So part of the SAMHSA cheer involves you moving. So first, make sure you have a little bit of space to stand up around your chair because you're about to do this, right? So give yourself a little bit of room. And now here are the rules. Go ahead and sit down for a second, but I'll tell you the rules. You're going to stand up in a minute. I know, see, people are like, these are alphas. You guys are alphas. You're ready to go. So don't worry, you're going to get a chance. Here are the rules. When I go like this, you are going to, this part of the room right here, this sort of segment, is going to stand up and you're going to say SA, and then you're going to sit down. Stand up, SA, sit down. Then I'm going to go like this, and you're going to stand up and say MH for mental health and sit down. And then that side of the room, normally I would be moving around. You guys can hear me. I'm going to use my outside voice. You guys are going to stand up and you're going to say SA. And how nice is that? Are you guys ready for this? Do you have a safe space around you? Did you all sign the disclaimer? All right, here we go. Ready? Go. SA! MH! SA! Fill in the blank. Make sure that you know how to email me. This is the most important part of the presentation, which is why I put it first. The first key to success, knowing who you are, why you're doing what you're doing. The other reason that I'm doing what I'm doing, because of data. In fact, I'd like to give a shout out to Bruce Thayer, who's the man who put me on the data path about 2 decades ago. And he's the reason I ended up in public health. And he taught me that if you can't measure it, it's not real. And you can measure pretty much anything. What we know in public health is that there are a lot of data out there. The data don't look good, and those data are actually people. Every state has experienced an increase in drug overdose deaths over the last few years. The most recent hard data that we have from 2017 to 2018 showed that at least in 14 states, it was a little bit lower, right? This is the last NCHS data brief that was published on this on final data. So that's good news. Let's take a look at the rates for the Region 4 states. What's nice is that there is no Region 4 state in that top 5. Rates are great because they control for population differences, right? When we're comparing one area to another area. Also, they control for different age distributions. So we can really make decent comparisons, right? So none of our states made the top 5, but here's a problem. There's one state in the top 5 for counts of deaths. And what state would that be? It's just coincidence that I happen to be here in Florida. Counts are great because they really speak to the burden of need. What is the level of prevention effort that you're going to get in the field to address this problem? What we know is that there were over 60,000 drug overdose deaths this is 2018 data. These are the most recent data that we have that are hard data on this. And 2/3 of those were due to opioids. Isn't that interesting? This is actually a decrease from the previous year by about 4.1%, which is encouraging. We know that for every one person who died, 11 reported a heroin substance use disorder. Now, there are blanks in your handout, so you can track this. You're also going to get these slides at some point, but isn't it fun to follow along on your handout? We know that for every one person who died, 36 reported a prescription opioid substance use disorder. Where do you think people are getting these prescription opioids in order to use, misuse, and overdose? Who are they getting it from? Say it again. GP, yeah, GPs. So practitioners, dentists, oral surgeons, friends and family, and neighbors' medicine cabinets. Yep. Guess what? It turns out you're right. It's prescribers and it's friends and family. That big gray pie and blue pie, and this pie. And I hate pie charts, but this pie chart's pretty all right. I didn't make it, but it's pretty clear, right? If you're going to make a pie chart, I would say only have 3 sections and make sure it's really obvious so that you don't have to add all the numbers and words. But yeah, friends and family, that's where they're coming from. We know that for every person who died, 220 misused opioids in the past year, right? So they use it for a purpose that it was not intended. We know that for every one person who died, over 1,000 filled an opioid prescription. That was me after going to the dentist. Filled the prescription, looked at the bottle, went, oh, I didn't need to fill that prescription, disposed of that bottle, right? So, but I was one of those. So maybe you were too, even if you didn't use it, even if you didn't develop a disorder, right? It's interesting that that's still happening. Even if you don't ask for it, you'll get it. So this should come as no surprise that we're seeing the non-fatal emergency department visits on the increase year after year. Notice that there are no data from Florida. That's why it is gray. So we don't really know what's going on in Florida. But in at least 10 of these states, there was still an increase by about 3.5%. So these are syndromic surveillance data. They change regularly, but this is from CDC's Enhanced Opioid Surveillance System, and you can check out their reports online. They update it pretty recently or pretty regularly. The good news is nationally, still overall, these are preliminary data, we're down. Right? So drug overdose deaths are down by about 0.8% by the most recent data. They haven't been finalized yet, so this number could change, but things are looking good, at least in the big picture. Yet, that's not the complete picture. Because despite disorder, we still know that there are these massive treatment gaps, not just for substance use disorder, but for mental illness. Right? And there are a number of things. We could speak for days on what accounts for these treatment gaps. But one is workforce, the other is curricula. Right? People aren't trained to do this job, so why would they do the job? Right? And then we're trying to find people to do the job because it's a hard job. So why am I showing you a picture of Benjamin Franklin? What do you think? That's actually a rhetorical question. You know why. I'm going to step away from the podium for a second. You know why? Because it's all about the Benjamins. We need resources to do our job. That's why we have people who are advocating for us at the legislature. That's why we're trying to create budgets that include substance use disorder training and plan for our workforce. So it is about the resources, but it's also because Ben Franklin is quoted with a phrase. And there are only 2 quotes in this whole presentation. The first one is this: if you fail to plan, you're planning to fail. Right? So I want to share with you a little bit about a plan and the bigger picture HHS partners that are helping you in this fight, right? So not only do you have partners, but we have a plan. This is a picture that summarizes all of your HHS partners. In your handout, you can play this at home. There is a crossword, identify the HHS partner crossword. It's in your handout. It'll make you really popular at parties. I encourage you to take it along and test your friends and family. These are the answers. These are not in your handout, so that's why you have your phone. Take a picture of it, or you'll get these slides. But we are all working with you as partners, and we have a plan to deal with opioids in particular. There are a number of other plans we could talk about, and this is the plan. You can learn more about it at hhs.gov/opioids. It has 5 points. And as I go through the next few, how what we're doing programmatically tracks to many of these points. The first thing is, in addition to our block grants, we're providing better services, better prevention, treatment, and recovery services by giving states and tribes a lot of money that is specific to opioids. So in SAMHSA talk, if you hear someone talking about SOR, STR, or TOR, this is what they're talking about. So you can now speak SAMHSA speak, which is really important, right? Speaking people's languages. The public, we listen to the practitioners on the front lines, and we increase the flexibility of that money, which is exciting. In addition to that, because we are a public health agency, we're data-driven. So we're always working to improve surveillance. We have expanded and accelerated the distribution of our National Survey on Drug Use and Health. That's where all of those numbers came from at the start of this presentation. This is the #1 source for behavioral health information in our country. The most recent data out are 2018 data. We're still crunching the numbers for 2019. Unfortunately, we produced these state behavioral health barometers that you can see on the right side. They're just a little bit slower. So we have the 2017 one that's out right now. We'll get the 2018 out soon. We've continued to expand access to and use of overdose reversing drugs. Like this, who has some of this in their pocket right now? Anyone? Yeah, good. Even if you don't have it, who here, raise your hand, raise 2 hands if you've taken some training on how to use this. Anyone? All right, that's better. Good. If you don't have it, if you haven't taken a training on how to use it, there are free trainings all over the place, right? You can get this for free as well from pharmacies. They will give this to you so that you can save a life. It is just as important as knowing how to do CPR and complete. And overdoses are happening all over the place. If you think you're not going to encounter one, then I think you're fooling yourself, right? And we are always the easiest people to fool, right? When we don't want to believe we're going to encounter an overdose. So this is something that we're doing. We're doubling the funding, dispensing of naloxone way before 2019. In fact, these data are out of date, and that tops out at 250,000. There are now over 280,000 doses that have been dispensed. Right? So these data are not even current. What's even better is the last data point from our program that we funded on this, which I believe was the end of 2019, reported over 10,000 overdoses reversed. Those aren't just overdoses, those are people. 10,000 lives that were reversed because somebody like you went and got that little nasal spray and figured out how to do it and put it in their pocket. Okay, just wanted to pause on that because that's really important. If you want to know more about what SAMHSA is doing grant-wise, go to our grant tab online. What's really cool about that is you can see all of the training materials and who's eligible. You can watch the videos that everybody who applies for a SAMHSA grant gets to watch. You can figure out if you could apply for a SAMHSA grant. I encourage you to seek out a university as a partner because they're a fantastic partner in this. They've done it before and they can help you succeed. So always seek out people who do this stuff. If you just want to know, maybe you don't want a grant, but you want to know who's got your tax dollars, and I know I do, go to your state, click on your little state there, and look at that. Here's Florida's summary for fiscal year 2019, both discretionary and non-discretionary. You can also see who got that money and what they did with your tax dollars. So if you're curious, grants, we have a national network of technology transfer centers. Before 2018, these technology transfer centers are addiction, prevention, and mental health technology transfer centers were only accessible to grantees. In 2018, it became open to all of you. This is a picture of our addiction technology transfer centers. They have provided technical assistance in the last 2 years to over 50,000 people just like you. These are the primary contacts for the 3 centers that we have in Region 4. These are the top of the food chain for those places. This is not their general landing page. These are the heads of those technology transfer centers. These are the people who wrote the grant to SAMHSA to become this thing to help you all out. So I encourage you to reach out to them. We're helping practitioners and expanding evidence-based treatment for things like opioid addiction through websites like this, the Provider Clinical Support System. This provides 24-hour Data 2000 waiver training. So if you're a prescriber and you want to be able to prescribe any of the FDA-approved medications for medication-assisted treatment, you can go get your waiver here. There are also webinars. They provide mentoring. They will hook you up if you want to work in addictions. We know it's working because we're tracking the number of waivered providers all around the country. If you don't know what a data waiver is, if you don't know what medication-assisted treatment is, email me or contact the university or ask somebody in the field. It's really important. We also provide rapid state-targeted technical assistance through the Opioid Response Network. This is really just the American Academy of Addiction Psychiatry and about 27 partner organizations who volunteered to answer your questions in 24 hours, roughly. If you submit a request, they will answer your questions about opioids, about substance use disorder, what have you. And this is usually a team specific to your state. So they're here in Florida somewhere, which is exciting. If you want to know what works from SAMHSA's perspective, we collected it all on our evidence-based research, the findtreatment.samhsa.gov treatment locator. So if you know somebody who needs help, this is where you can direct them. What might be confusing is you've recently seen the launch of findtreatment.gov. Remarkably similar, no? It is the same library of substance abuse providers, but none of the other providers. It's more user-friendly and has these cool pictures, but it doesn't have all of the resources. So depending on what you're looking for, maybe you're going to opt for user-friendly, maybe you're going to opt for the more broad, robust treatment locator. I don't know. We produce other guidance. I say new-ish guidance because TIP 63 and medication-assisted treatment information is so cutting edge and is changing so rapidly that even though we just published that a little over a year ago, we're already revising it, and it has been pulled from the SAMHSA website. So there's a new one up there, but there are resources available that are for free that your tax dollars have paid for that you ought to download or tell people about. If you do not already have a SAMHSA app on your phone, does anyone? Raise your hand if you have a SAMHSA app. Oh no. Okay, here's your homework for today, right? And download an app. And I'll tell you, my favorite is the Disaster app because there's psychological first aid on there. There are a number of other resources on there. If you happen to work in a mental health setting where you have to make referrals for suicide risks, Suicide Safe is really cool. Talk They Hear You is also neat, but I like the Disaster app. I've had it on my phone for years. Get an app today. Right now. Really. There's no excuse not to have an app on your phone. You've got all these other apps, right? Okay, so how am I doing for time? Where are we at? How much more time do I have? It's great, but it's no good if you guys burn yourself out. So we're going to do a little bit of self-care. We're going to do a personal resilience plan. I want you to tear that last page off of your handout. It's a blank page and has our experience of anything like, say, pandemic coronavirus is based on our expectations. So when I talk to officers at the CDC about being deployed or a pandemic outbreak, and also when I talk to them about personal protective equipment, like this resilience planning is for you, this is your behavioral health PPE, by the way. They have certain expectations. This is what they believe was going to happen. They thought they were going to be in the big suit going out on the wing of an airplane. That's what they thought. But then when they got deployed, this is what it looked like. They were sitting in an office, and guess their PPE was the wrist rest and the ergonomic chair, right? That's what their actual deployments looked like, and that's what their PPE looked like. So today, this is your PPE. So I want you to fold it in half, and I want you to write down your name. I want you to write down, let's say you can prepare yourself for pandemic outbreak, and today's date and where you are right now. Go ahead and write that stuff down. Pandemic outbreak preparedness, or just coronavirus, COVID-19, you could do that. Today's date and where you are right now, because when you're planning for any event, when you're doing your personal resilience planning, it has to be event specific. It's not one size fits all. You can't do this now and have it apply the next time you maybe get deployed to an emergency operations center for something or the specific. So now we're going to buddy check. Look over at your buddy. Do they have all of that information? Look over at your buddy. Raise your hand if your buddy has that information. Raise it. Let me keep the hands high. I need to see hands. We can't move on. Oh my gosh. Let's see. Raise your hand as your buddy gets the information. I'm waiting to see more hands because we need to be oriented ×3 before we can move on. All right. Go ahead and put your hands down. If your buddy doesn't have that information, if they don't know who they are, where they are, or what day it is, you need to keep an eye on them right now. Really. Why? Predict problems and personal challenges and still keep an eye on that buddy who didn't know who they were because they're dangerous. Now, most of us get a chance to go on a deployment, or maybe we're doing our day-to-day job and maybe related to pan flu or pan coronavirus because of our employer, right? So we can expect what's going to happen the next day on the job, right? It's really easy to expect what's going to happen. And the more we can anticipate what's going to happen to us, the easier it is to prepare. So we usually don't have a lot of anxiety going to our day-to-day job. But what if tomorrow you get the call, hey, you're going to go respond to COVID-19. You're going to go to the airport at the quarantine station. You're going to be taking little temperatures in people's ears, and you're going to be doing this or that. And you're like, whoa, I'm excited. And the problem is you don't really know what's around the next corner, right? Like, what's stressful to me isn't stressful to you, and you don't really know what's going to happen next. So suddenly you're freaking out. These are some things that you might anticipate on a deployment. These are also some things that you guys might anticipate happening during a response. I want you to write down some of the things you think are going to happen in the next few months or weeks that you may anticipate. You may have already experienced something like people not wanting to shake your hand, right? Write down some of the things you think are going to happen related to flu or related to coronavirus, because these are really the same thing. In the next few weeks and months, what are the stressors you're going to see in the news socially? Hopefully you're not going to witness mass destruction. Hopefully you might see limited resources. You might encounter difficult supervisors or colleagues. You might have austere living conditions. Hopefully you won't lose any colleagues or have to make life and death decisions. Hope not. You might have more intense workloads as people end up teleworking or getting sick. And also write down what things might challenge you personally. Like if you're a hugger, not being able to hug people, yeah, I mean, that's legit. You know, that's a connection thing. So what are your personal challenges related to the next few months? At least one. Think about like what might be really tough for you. Yeah, if I'm a hugger, and it's hard not to go in for that above, side, whatever have you. All right, now on the right side of your little handout, write predict or prescribe protection. This is how you take care of yourself. Now, some of you may recognize the Marvel's X-Men. They had this really cool room called the Danger Room where they prepared for their missions. This is our Danger Room today. So we're going to practice a few things. First, we're going to breathe, right? Our only unconscious process that is directly related to our nervous system we can consciously control. Inhale for 4. Give it to me. Hold. Exhale for 4. Hold. And repeat it a few times at your own. Right, now we're breathing. That's good. That's a first sign, right? If you're not breathing, notice 3 things that are not going to disturb you or bother you. Just acknowledge them in your head. Look around, name them in your head, and then notice 3 things you can touch or feel that don't disturb you at all. Like I have a water bottle, I have a hat, I have this wood stuff. And then I want you to listen 3 things you can hear that don't disturb you. If you're ever feeling anxious, if you ever need to refocus on what's important now, you can go ahead and do this. Nice refocusing drill, right? Who recognizes this? Yeah, holodeck, right? For you Harry Potter fans, this is the room of requirement, right? It becomes whatever you want. For example, like Jean-Luc would go down, the captain of the Enterprise would go down, and he would make it become the south of France with his favorite pit bull. Everyone needs a favorite pit bull, right? So he could recover from his taxing missions. And you guys can do this too. Make a note on your handout. What's your happy place? If you were today going to go and include a picture on your telephone of your happy spot, where would that be? If you already have it, don't bother writing anything down. If you know it's on your phone. If it's not on your phone, I encourage you to create your own holodeck. This is Joshua Tree. This is me driving into Joshua Tree like I do every December to go rock climbing. It's my happy place. When I look at that picture, I'm not here, as nice as this is, like, oh, I'm at Joshua Tree, right? So if you don't have a happy spot, you need to go and get one on your phone. We're going to do one other thing. Like these are some other things that you can do to help you stay safe during COVID-19. I'm going to ask Ellen to help me out. Let's do what's going to keep us healthy and safe during COVID-19. All right, you ready? So it's like, hey Ellen, it's great to see you. I haven't seen you for a good go. 1, 2, 3, 4. Good to see you. All right. And every time I see you for the big handshake, right? What are you going to do to keep yourself healthy while people begin to social distance, while people begin to look at you like, oh, is they coming in for the hug? I don't know. Right? What are you going to do? Because our society is changing right now. The horses left the stable in our national response to this virus, right? And so start to get ready for that. Now, flip it on the back. Engage your plan. Write that down. This is important to know. Why is it important to know how to engage your plan? We're going to do an exercise. 5 minutes? Okay, we're going to hurry. We're going to do an exercise, though, because this is fun. Everyone stand up for me. We're going to risk a little personal contact. I want you to hold your left hand in front of the person next to you. So, like, if I'm standing here, there's someone next to me. Your left hand out in front of the person next to you. If there's no one on your left, then you can adjust, right? If there's no one on your left, just adjust. Now I want you to put your right finger in front of the hand in front of you. So, adjust if there's no one around you. So you should have your finger in someone else's hand. Maybe it's just going one way. You don't have any options. Now here are the rules. When I say gotcha, you're going to try to capture their finger and avoid being captured. You ready? Ready? 3, 2, 1, gotcha. All right. Okay, wait. I know it's not fair. Lefties, right? Lefties. So let's try it again. Switch hands. Switch hands. We gotta be fair to lefties in the crowd. Ready? 3, 2, 1, gotcha! All right. In addition to hand sanitizing right now, what did you guys notice what happened because of that? What changed because of the activity? What changed because of the stress? Some people got like super into it, and some people kind of went, whoa, I'm not even going to stand up. I don't care what King says. I'm staying in my chair, right? Right. So even an experience of meaningless stress exaggerates our natural tendencies. And it's really important for us to be aware of this, right? So we can better handle it. Like on our day job, right? Like I know Bruce, when he walks into his classroom, he's like this. He's the boss. I know because I was there. I saw it. You walk in, right? And maybe, but then maybe you go somewhere, like maybe you go to a conference or you're working in another office and you're not doing what you're accustomed to doing, or you're doing something new and you're more like the little cub, right? Maybe that's you. That was me in Bruce's class. Or after several days, 15-hour days, you're like dog tired and you're just zoned out. You can't handle it. Or you're at a conference, right? Or you're somewhere else and you can't get your mocha frappuccino like you want. And you're like, they didn't have soy milk. They didn't have it. So all that really matters is you know what you look like under stress, right? So you can anticipate it and you can know when to engage your plan and avoid any catastrophe. Like all these. That's my cat line. I know. Right? I had to. So these are some common stress reactions. I want you to write down what you look like under stress on that engaged plan. And you can even say, I will engage my plan when. This is contracting with yourself, social contracting, right? We do this. I don't know how predictive this really is of actual engaging your plan, but do it. When I come to your keynote, I'll do what you ask me. Promise. So it's normal to expect people to bounce back, right? Right? Yeah, okay, so some people have looked in the History Channel, right? This is for the newer folks in the crowd. We'll go with Elastigirl because the whole point is most people bounce back. Most of you have probably gotten by just fine without writing down your personal resilience plan, right? But just think about how much more super you would be if you actually had a plan that you wrote down and you worked it a little bit, yeah? Because guess what? You guys are at risk. We know the literature tells us that 10 to 20% of you will develop a new onset disorder after responding to a stressful event. Like say you get deployed or maybe COVID-19, you get roped into that response somehow, right? And what's worse about that is that you guys are going to suffer in silence more than anybody else first responders have a tendency to not ask for help, and we don't know why. And what it looks like is you're driving down the street with a taillight out. You think you know what you look like under stress. You think you got this handled. I'm a pro, right? But wouldn't you rather a buddy say, hey, Ellen, pull it over. You've got a taillight out. You need to go take a break, or you've been working these really long hours. Take a day off. And we're the last ones who want to take that advice, right? So what I want you to do is on the front page, write the name of who you're going to call when you start to feel a little too stressed out. I don't care who it is. Who's your battle buddy? Write their name down. You probably don't know their phone number because none of us have memorized phone numbers anymore. But write their name at least, so you have that at the top of your frontal cortex there. You can actually access it rapidly, right? If you don't know the number for your EAP, go ahead and write down the National Helpline. This is something SAMHSA sponsors. But also check out your EAP. They're great. If you don't know that number, if you've never bothered to look, use it. Really. They want to be used. They want to help out. So super on your own, but we're so much more super when we work as a team. So you've got your battle buddy. You've got SAMHSA now. You know that there's somebody in your region who's your partner. If you do that HHS crossword, you'll know a little bit more. It's a lot of fun. Trust me. You'll have no idea. You know your partners. Please use us. Remember to stay flexible. You're the stars in my sky, and you're great on your own, but constellations are even cooler. So I'm happy to be here. Thank you guys for playing along.
Opportunity for a couple questions, literally 2 questions. So are there a couple questions you'd like to have from the audience for Captain King?
Oh, and then I have a parting shot as well.
Okay, good.
I'll wait for the
Questions?
questions.
Comments?
Hi.
Go ahead. Speak loudly.
Yeah.
Sure, I can do that on the teacher. My name is Tamara Gibson, and I'm from the Florida Department of Education, Office of Health Schools. Thank you so much for your presentation. Our office works with health educators in K-12 to help mitigate the numbers that we see, that rising population of substance use and abuse issues in the college age, which is our focus for today. But I was wondering if you have any suggestions that I can bring back to FDOE for addressing substance use and abuse. There's 3 State Board of Education rules that were passed this year. One is substance use and abuse health education, and our office works to support and provide information and technical assistance to school districts. We have a summer academy in June that we'd love to invite you to as we work with teachers to address this. So is there any information you can give the K-12 system as we work to lessen the numbers?
Yep. So what's really neat is the Mental Health Technology Transfer Center that we have, only one that's based out of a school of public health in the country. And their main topical focus is school health and school mental health or school behavioral health. So it covers both substance use and mental health. They are producing regular trainings, webinars, resources focused on that. They just produced a guide for behavioral health in rural schools that's online and free right now. So if you get a hold of these slides, call Ben Druss at Emory or email him and check out their website as well, the MHTTC network. That is their sole focus. So that's really exciting to me that you asked about that, because kids and mental health, or in just any kind of behavioral health in schools, is a big deal, and it's a great opportunity to make a difference. It's a great intercept. So that's what I'm going to say.
But Captain King, if anybody has a question,
Yes.
there's his email. He can direct you to the correct resource within the federal government.
Yep.
We also we're live streaming this, and we also in a week or so be I guess marrying the PowerPoint to the audio, and that will be available on our YouTube channel. So if you need to follow up, please do so with Captain King, right?
Yeah, please call me.
You had a slide of 3 contacts, and Ben was one of them, right?
Yep, he was the middle one. Yep.
Thank you.
One more question.
One more question. I'll have my parting shot. There's one.
Go ahead.
Hi, my name is Chelsea, and I'm a doctoral student in the College of Education, and I'm studying the recovery program. You mentioned earlier evidence-based research and operating as a potential was real. Can you measure it? And if it can't be measured,
Mhm.
which positions substance use in a post-positive paradigm and generalizes and synthesizes what leads into use and use and ultimately recovery. Can you highlight how SAMHSA and contribute to substance use, abuse, and ultimately recovery?
Yes, so that's a fantastically articulated question. You didn't write that down, did you? So that was awesome. So when SAMHSA is looking at the world of recovery, and not just recovery, but sort of the prevention, treatment, recovery cycle, when we think about social factors or even building resilient communities, we're looking at a lot of the social determinants of health literature. So that you may know that the WHO has this, logic model for what creates a healthy community, and it has a number of input necessarily well, if that makes sense. So the indicators that are used in that WHO model have been measured across every state in the United States for many years now by the CDC, and they have a data set that's related to that. Those type of data, not necessarily that data set, but those type of data also inform our SAMHSA policies when we're looking at the social programs that we support with your tax dollars. So when we're looking at what builds a healthy community, for example, our substance abuse block grant monies, we require very few things of our grantees, but one of the things we require is that 20% of their block grant dollars be spent on primary prevention. And so for example, in like the state of Tennessee, where I was just recently, our grantees have partnered with their Office of Primary Prevention on projects like walkable streets, like food security and food access in rural areas, like supported housing and employment. Things like this that actually knit a community together and give hope in a community. And those are all measurable and those are all real. We can say that we think, one intervention works, but until we actually measure it working, that's a big shift in how the federal government, particularly SAMHSA, is funding things, because for many years, like that evidence-based resource center wasn't there. That only occurred in April of 2018, I believe. When we brought all of our different disparate sources of information together and we focused on things that we actually had a solid evidence base for. Now, we also have promising practices which have maybe a little less solid evidence base, but the goal is, if you're going to do something, make sure you can measure it so that you can make sure it's worth your time. Because if we're really in the business of saving lives, we don't want to leave it up to guesswork, right? It's too important a job to just say, well, I hope it works, or I believe in it really strongly. You have to know it works, or else you need to pivot. And my parting shot is this. You just did that resilience plan on a blank sheet of paper. That's the lo-fi version. Now the last page in your handout is actually a trifold brochure that I created for my mental health response teams. So that's something that I made personally to distribute to my USPHS mental health response team members, based on a stress inoculation approach, right? Where you anticipate what your stressors you're going to experience, you prescribe your own personal best protection, and you practice that protection, and then you know when to engage that system, right? So that 3-step process of anticipating, planning, and then engaging the plan will help you stay healthy. If you forget everything else I say besides my email, use that plan, use it with people that you work with to help keep you guys healthy. Because the 3 keys of success are knowing who you are and what's your why, working with others and helping others, and then taking care of yourselves. And you have to do all of those things to stay in this field for very long. So thanks.
Thank you,
Yeah.
Michael.
Bye-bye.
And just a couple more pieces earlier that we are live streaming today. The hashtag is #CFC Center, and then hashtag FSU CSW, which is Florida State College of Social Work. So look for that on Twitter if you're on Twitter, and like it, or hopefully you will enjoy responding back to that. We are also live tweeting the event, or live streaming the event to our Facebook page. It will be posted to our YouTube channel, the College of Social Work. And as I said earlier, the PowerPoints will be married to that live stream. And so more of the content will be available to our friends out there who haven't been able to join us. So I'm going to invite Jeffrey Harmon up to speak to us about the financing of substance use disorder and behavioral health care. You can read about him in the program, but Dr. Harmon is with the College of Medicine, and he is a health economist. So he is going to wow us with some numbers today. And help me find our financing. There we go. And thank you so much, Dr. Harmon, for agreeing to be with us today.
Okay. So good morning, everyone. That's a hard talk to follow. I'm going to show you the example of what is not full of pictures and active learning. So I'm just going to be kind of giving you some facts about financing and treatment of substance abuse. I'm a health economist and a health services researcher. So I study the delivery of healthcare. My research is focused on delivery of mental health and substance abuse care, but also on Medicaid policy and how Medicaid policy impacts the delivery of care. So today I'm just going to talk about give you an overview of what's the substance abuse treatment services that are available in Florida, how those are financed and what we spend on those. I'm also going to go over some relevant recent health policies related to substance abuse, and then just briefly go over some issues related to things that affect the demand for substance abuse services, as well as access to substance abuse services. All right, so I went to SAMHSA actually and pulled this information. So there are 793 facilities in Florida that provide substance abuse treatment. And so I'm going to be giving you some results from the National Survey of Substance Abuse Treatment Services. And there were 706 good sample. So one thing to notice is that the majority of them are private for profit. 54%, 41% are private nonprofit. Only 5% are run by government, and that includes all kinds, local, state, and federal. Although 95% of these treatment facilities have been accredited, licensed, or certified to provide some substance abuse treatment. So what are the types of substance abuse care that are available to people? So out of all of these facilities, 82% of them offer some form of outpatient treatment. So in 76% of those cases, they just offer kind of regular outpatient substance abuse treatments. 42% offer intensive treatment, and about a quarter offer day treatment or partial hospitalization, and about a quarter offer methadone and buprenorphine maintenance or naltrexone treatment. Just as an aside, so in the previously they're saying so you need to have certification to provide substance abuse treatment, but you don't need any certification to prescribe addictive drugs, which just seems a little backwards to me. All right, so back into the types of substance abuse care. So only 29% of facilities offer some kind of residential treatment. About 60% offer it for short stays, so less than 30. 71% are actually offer long-term treatment. And these are of the residential treatment facilities. Only 8% of facilities offer inpatient treatment, but among those that do offer inpatient treatment, nearly all offer a detoxification services, and about 3/4 of them offer just inpatient treatment for substance abuse. And when you look at kind of some specific services that are provided, nearly all of them offer screening for substance abuse. Same thing with comprehensive substance abuse assessment and diagnosis. They almost all offer drug and alcohol urine screening, and as well as counseling, both individual and group counseling and discharge planning. So these are kind of the services that almost all of them offer. You can go down the list, and there's actually a long list of various other services, but they are not sort of universal. So these are kind of the universal treatments that are offered at all of these. Looked at among these facilities, what type of payment do they accept? Okay, and this is important, because money kind of rules the day, and it has a big impact on whether people are going to actually use the services. All right, so not surprisingly, almost all of them will accept cash. 5% don't, and those would be the government-run facilities. So about 3/4 of them accept private health insurance. But one of the things that I thought was really striking is that the minority of these facilities don't accept public insurance. Only 38% accept Medicaid. And Medicaid covers a very large portion of the people who are suffering from opioid addiction. 26% accept Medicare, and that's also significant. There's a lot of older Americans, who have been on pain medication for a long time and are also suffering from these issues. 31% accept military insurance. 30% about some sort of state-financed health insurance. This would be aside from Medicaid. And 62% of them have a sliding fee scale, right? So if you have a low income, you'll pay less than somebody with a higher income. This is not what we want this to look like, right? They should all be accepting Medicaid. They should all be accepting private insurance. And so this is just kind of showing you a trend in spending for substance abuse services. This is not Florida specific. This is across the U.S. So one thing to notice, so it started in 2006. We were spending about $18 billion substance abuse services, and that's gone up to $56 billion by 2015. So there's been a pretty rapid increase in the amount of money that we're spending on substance abuse treatment. And some of the things I want you to notice is that, so when you look at, so it used to be that other state and local sources, so government sources, were paying for these services, and you can see that shrinking. It went from 30% down to 17%. And so what is that being replaced with? Well, Medicaid is having an ever-increasing portion of the spending. The Affordable Care Act is one of the reasons why, because it requires substance abuse service care. But you can also see that private insurance, which is the kind of orangish red bar there on the bottom, that's increased from 19 to 29%. And things like Medicare and out-of-pocket, those have remained relatively stable over these last 10 years or so. So I just wanted to briefly mention Medicaid. So 40% of adults with opioid use disorder are covered by Medicaid. So Medicaid is really important, right? But we saw that only 38% of facilities actually accept Medicaid. But if you do have Medicaid coverage and you find a place, right, you're more likely than those with other forms of coverage to receive substance abuse treatment, right? So Medicaid does work in increasing access to treatment. And it also pays for a wide range of substance abuse treatment. It pays for inpatient and outpatient. It pays for medication-assisted treatments. And Medicaid expansion can further increase access to treatment. So, one of the reasons why we saw that increase in Medicaid spending was because of Medicaid expansion that has gone on. And so that's going to be an important piece as more and more states, hopefully Florida will follow soon by expanding Medicaid. That will help increase access to substance abuse services. Although one of the things that concerns me is that some of these states that are sort of late adopting Medicaid expansion are doing things like implementing a work requirement or adding co-pays and cost share, right? And then so you're basically decreasing access to Medicaid by doing that. And and evidence will tell you that that's not really a wise way of going about this. And of course, if you qualify for Medicaid, you're really poor. So any kind of cost sharing is going to be a major barrier to you. All right. So now I want to briefly go over some of the recent federal policies related to substance abuse that are relevant to financing. So I'm going to talk about the Mental Health Parity and Addiction Equity Act that was passed in 2008. The Affordable Care Act in 2010, the Comprehensive Addiction and Recovery Act, CARA, which passed in 2016, and then finally the SUPPORT Act, the Substance Use Disorder Prevention, that promotes opioid recovery and treatment for patients in the communities. And that was passed very recently in 2018. All right, so the Mental Health Parity and Addiction Equity Act. So what that did is it required insurance groups offering coverage for substance abuse disorders to make those benefits comparable to general medical. You might have had to pay 50% of the cost of your substance abuse treatment services, but only 20% of the cost for general medical care. Right? So this policy made it so that if you offered substance abuse, you had to make the coverage for that, the benefits, basically similar to what was going on for your general medical coverage, had to be comparable. And so that meant that, you had to have the same deductibles, you had to have the same co-pays. If there was an out-of-pocket maximum, it had to be the same. Like all of these things before the passage of this were very different, and there was much more restrictive for mental health and substance abuse care. And also things like treatment limitations. They say you only get to 4 visits for substance abuse, where you wouldn't have that kind of limit if you were getting diabetes care or something like that. But health insurance groups could still not offer substance abuse coverage, right? So if they didn't offer it, they didn't have to offer it. And so you could be in insurance, you could have insurance that didn't cover substance abuse at all. And that continued even after passage of this act. So the Affordable Care Act, which was passed in 2010 and really kind of kicked in 2014, enacted 4 primary mechanisms to help combat substance abuse. So first was the insurance covered expansions. By Medicaid expansion, that was a way that a lot more people could gain access to health insurance coverage. And then also the ban on pre-existing conditions. That was part of the Affordable Care Act. And substance abuse was a pre-existing condition that insurance companies could say, we're not covering you because you have a history of addiction and substance abuse. It also required the inclusion of substance abuse treatment as an essential benefit. So part of the Affordable Care Act, it said, if you're going to be on the insurance market, you have to offer this basic package of services. The essential services were included, and that included both screening and brief interventions. Right? It didn't require, that you do inpatient treatment or residential treatment, but at least it required some form of substance abuse treatment. It enhanced parity. So parity rules now apply to all private insurance plans, not just those that happen to offer substance abuse coverage. And it also provided opportunities and incentives to integrate substance abuse care into mainstream healthcare, right? And so this was through things like medical homes. People are familiar with medical home concepts in this room? Maybe not. So in medical homes, it's like a team-based approach to providing care, and it's kind of this comprehensive whole person care approach. And then also accountable care organizations, ACOs, it's another one where you're basically integrating all the care, and mental health and substance abuse has been a big focus of both medical homes and accountable care organizations. So next was the Comprehensive Addiction and Recovery Act, CARA. So that authorized over $180 million per year to respond to the epidemic of opioid abuse. That's good, but that's like a little tiny drop in the bucket. That's not nearly enough money, but it was something. And it had provided funds for prevention and treatment programs. It focused on funding of community-based programs. So this was more towards the prevention side of things, because that's where the prevention is going to go on in the communities, not with like individual providers. And it also included grant funding for residential opioid addiction treatments of pregnant and postpartum women. So this is obviously it's a big issue. And then finally, the SUPPORT Act. The SUPPORT Act was specifically addressed the opioid overdose epidemic. So, and what it did is it allowed for more flexibilities, prescriptive as it was before. It said, what are your needs? You can figure out how your state can use this money best. It established grant programs for comprehensive recovery centers for opioid addiction, as well as establish some best practices. All right, so some kind of guidelines for how we should be providing recovery housing. And really the focus of the SUPPORT Act was on increasing access to opioid addiction recovery services. All right, so finally, I'm good on time. All right. So I want to just mention a couple things about the demand for substance abuse services. So one is these policies that I just talked about, they helped increase access to substance abuse treatment to help meet the demand for these services. And the demand for substance abuse services has been significantly increasing. So I showed you a slide earlier that showed this big increase in spending. So just in the past 5 years, spending for substance abuse services more than doubled. We went from 23 billion in 2010 to 56 billion in 2015. I wasn't able to find more recent figures, but it's even higher than that now. So I'll show you in a second that you can see there's a really rapid increase. And a lot of this is due to the steady rise in opioid addiction, although we did see that we're finally maybe seeing it not increasing, leveling out a little bit. But that has increased the demand for treatment. And so this is looking, so this figure is basically showing you overall spending for mental health and substance abuse treatment over the last 10 years, well, 2006 through 2015. And so the blue bar on the bottom, that's showing you mental health spending, and the orange bar on the top is showing you substance abuse. And so you can see that everything is mental health has been, slowly increasing, which is very good, obviously. But you can see that the substance abuse, there's almost an exponential increase in our spending for substance abuse treatment, and that has a lot to do with the increased demand, but also combined with these policies that have been passed to help increase access to mental health and substance abuse services. Right. So, what are the kind of things that affect an individual's demand for health services, for substance abuse services? So one obviously is need, right? The person, if there's an increase in the prevalence of substance abuse disorder, if somebody develops a substance abuse disorder and develops a need, right, that's going to increase obviously their demand for that type of services. Insight and awareness is also a really important factor in the demand for substance abuse services. So only 8.5% of people with a substance use disorder think that they need help and need treatment. So over 90% of people who are suffering from substance abuse don't think they need treatment. And so that is obviously going to diminish and how it's impacting their lives, and that they do have ways of helping. Stigma also is an important factor in the demand for substance abuse services. So people are going to be less likely to seek treatment if they think they're going to be stigmatized for getting that treatment. And that also kind of speaks to why we should be offering substance abuse treatment in primary care, and let's just call it primary care, right? Mental health and substance abuse is primary care, so let's just call it that, and we can remove the stigma. So some other factors that affect the demand, obviously, price. Some studies looking at how people respond to price. So as a little economics lesson, it's called demand elasticity. And so it's saying, basically for every kind of unit increase in the price, how does that decrease your use of services? And what we've shown is that the elasticity of demand for substance abuse and mental health services is minus 0.26, and it's minus 0.02 for primary care checkups, right? So what that's saying is that the price of a primary care checkup isn't really going to impact the likelihood that you go and get your primary care checkup, right? But you change the price of your substance abuse services or your mental health services, that is going to greatly diminish your demand, your likelihood of going to get treatment, right? So price matters even more for substance abuse and mental health care than it does for primary care. And this is also like for, emergency department visits. Like somebody goes to the emergency department visit, they're like, wait, how much is it going to cost? Nobody says that, right? They just go to it. But they go, wait, how much is this going to cost me when they're going to get mental health or substance abuse care? Insurance coverage obviously is important. So, if you have insurance coverage, which lowers your out-of-pocket price, you'll be more likely to get it. And then access to substance abuse providers is going to actually impact your demand. So if you think or you're aware that there are waiting lists to get into substance abuse treatment, you're going to be less likely to go and seek it and to sign up for it, right? If you finally came to the decision, like, I have a problem, I need to get substance abuse care, but you think you're going to have to wait a month or 2 months or 3 months. I mean, in Tallahassee, if you need specialty mental health care, you're waiting several months before you can get in to see that, right? So that's going to keep on. And so finally, I just want to mention some of the factors that affect access to substance abuse services. So obviously, healthcare infrastructure is really important. So the number of providers that offer substance abuse services and are accepting new patients and accepting patients with particular types of insurance, right? So that's going to affect your access to care. And it's going to vary for outpatient versus inpatient versus residential, who's accepting certain payments. The built environment is important. That's something that we don't always think about. So how long is it going to take? So let's say you're getting outpatient treatment. Maybe I have to take a public bus and transfer 3 times. And it's going to take me an hour and a half to get there, right? Then that's 3 hours out of your day just to get your treatment. So that's obviously going to, decrease the likelihood that you're going to get treatment. And then another important thing is just the social environment. So there's all local cultures, and local cultures are going to impact your access to care, whether your community is going to be offering that type of care. And things like social class make a difference, in terms of whether you think substance abuse services is something that we should be getting, the type of job that you have, and your social support. These are all types of things that are going to impact access to care. So like local matters. So, your local built environment, your local culture, those are all things that are important determinants of your access to substance abuse care. All right. And I believe that, yes, that is it. So thank you.
And I think we have, again, because our speaker kept on time, we do have the little cue. Go ahead.
With the CARE Act, I believe you mentioned greater flexibility within states. Has that been a good thing or a bad thing? Because I see sometimes flexibility means subversion of funding to other issues.
So your answer is yes. It's been a good thing and a bad thing. Because certain states will basically take advantage of the flexibility to divert their funds to other places where other states will be more proactive about it. So it's kind of a double-edged sword if you kind of go either way.
One more question? Yes, Bruce.
Apart from the emphasis at the state and local level and the federal level to enhance the availability of services and funding them, is there corresponding attention being given that the services we're funding with taxpayer money be research-based? They really have a demonstrated capability of helping people.
Well, so several of the new policies that have passed have really focused on providing evidence-based treatment. And so that hasn't always been the case for substance abuse services. And so there has been, so a lot of the recent policies have been really focusing on, let's look at the evidence and make sure that we are putting our resources to evidence-based care. So there has been some movement in that area.
We'll go one more, Jeff. Last one.
Between the need and what's available.
I don't have the actual figure off the top of my head, but there's certainly
It's
a sizable, substantial gap. Not only do people not recognize necessarily that they need treatment, but even people who recognize that they need treatment, a lot of them able to get the care. So even if they decide they want it, they don't really have the availability to them.
Okay, I'm going to do one last. Allison.
Okay, so I apologize if this is a question coming from my own ignorance, but why are substance abuse treatment facilities not taking Medicaid? Is it a treatment limit time?
It's due to how much Medicaid pays them. So Medicaid reimbursement rates are woefully inadequate. So generally speaking, a provider loses money with the Medicaid patient. Like what they get paid is less than what it actually costs them to deliver that care.
And they do much better in Medicare. Medicare is much more competitive, but Medicaid is a loss leader for a lot of providers.
Yeah.
So Dr. Harmon has agreed to participate in the development of one of our modules with Hugh Clark and myself on the financing of substance abuse and behavioral health care. So we appreciate that in advance. We're going to be using some of your slides. So we're happy to have you on board on working on this important topic. So
Happy
thank
to
you
work
very
on it,
much. And I think our next speaker is Dr. Tanya Wren. Dr. Tanya Wren is a colleague at the College of Social Work. And we actually applied for a SAMHSA grant to serve, is it okay? Go ahead. To serve homeless women with children. And we're still hoping that grant is successful. And take it away, Tanya.
Awesome.
Thank you so much.
Thank you. Thank you, everybody. I know we've been sitting for a while, and we have my presentation and presentation too distracting to me. So I just want to welcome people to joining us to this conversation. Today, we're taking the opportunity to highlight unique needs of women in relation to their substance use, abuse, and then also treatment. So we know women are biopsychosocially unique in ways relevant to all of this. And so it's an important part of the conversation when we think of treating this population. Oh, I'm an assistant professor at the College of Social Work. I apologize. And also the assistant director at the Institute for Justice Research and Development. And I look at the intersection of criminal justice involvement and pathways into it, primarily addiction. So currently 19.5 million females ages 18 or older have used illicit drugs in the past year. That's about 15.4%. But what we also know and what our recent articles are showing us is that alcohol use and death, alcohol-related deaths are increasing for men and women. Women specifically, and the gap is closing. Each year, over 200,000 women die as a result of alcohol and drug addiction. Again, as Captain King was saying, these are human lives that we're losing every single year. And while some trends are showing to be helpful, like Narcan, do you want me to scoot over? Okay. I'm not as tall as everybody else, is what I was just told. Even with heels, I'm at a disadvantage. So I apologize. And so each year, over 200,000 women die as a result of alcohol and drug addiction. And again, these are human lives, as has been highlighted for us. And so what we know, women typically become addicted faster than men. Women have shorter relapse periods, and they're likely to go to emergency room or die from overdose greater than men. Get women involved, engaged in treatment, how to retain them in treatment, and how to improve all of these rates. And over 4 million women are in need of treatment across the United States. So here are some statistics for you. I hope the graphs are better than just looking at a bunch of numbers that are black and white. So the most commonly used substances among women are alcohol and prescription medications. You can see from this graph, cocaine and meth are about equal for men and women. Prescription opiates, women are actually more likely to use them than males. Alcoholism, it's about half the rate, but what we know is that is closing pretty rapidly, especially among young women. So we're seeing an influence of women using earlier substances, alcohol specifically, as well as illegal substances. And so we're seeing a smaller gap when we look at rates and averages. And so although it can seem like, oh, women aren't doing that bad, what we know is they're doing a lot worse than they were doing a couple years ago, 10 years ago, 15 years ago. So women are more likely to be introduced to and initiate substance use through relationships. Those are both family relationships, but especially intimate partner relationships, which is very important to consider in their using patterns and how to get women out of their patterns of use. As I said, they have a higher rate of dependency, and they progress faster from initiation to use to the development of substance-related adverse consequences. So once they start using, they develop faster rates of use. they use substances at higher rates, they become more dependent, and their relapse rates are actually shorter than men, which is another reason that when we think about how to treat women, we have to think about time is of essence, even more so than men. I'm sorry. At the top, it's probably because I use a Mac. So I apologize for that, but it's what leads women to use. So what are some factors? And I think none of these are incredibly surprising, but what we know is that they're higher in women than men when we ask what led you to use and why are you using. And so to reduce stress and life pressures, there's more and more articles coming out about the pressure of being a woman in our society. The increasing demands as more women head to the workforce, but also try to do the work-life balance. And so we know that women are using substances because of that. To deal with trauma, women have higher rates of trauma previous to use and also once they have begun using substances. As many as 4 out of 5 women seeking treatment for substance use disorders report lifetime history of sexual assault. Let's just sit with that for a second. So not only physical, emotional, but sexual assault alone, which we know has alarming effect later on in a woman's life, specifically around their use of substances. And then also to self-medicate for mental illness, specifically anxiety and depression are higher in women who use substances. And so we see a comorbidity between these diseases, and that is also a reason that we have higher rates of relapse and increased time because of the comorbidity issue. All of them got messed up, I'm sorry. And here are some of the comorbidity issues that I was just kind of talking about quickly on the other slide. When you look at mood disorders and the intersection with substance abuse, about 30% of individuals are experiencing both a mood disorder as well as abusing any substance, alcohol, or illicit drugs. In terms of eating disorder, we see 50% as well. I thought that was rather alarming and eye-opening when we think of treating women and having them engage in. So sometimes it's using substances to take away cravings for food, and then they become addicted to them. And then physical and sexual assault, which I talked to you, this number ranges substantially. You see 55, you see 99%. I told you a statistic of 80%, which is, I think, the most reliable in the literature at this point. But depending on the study, depending on the different substances of use, we see anywhere from 55 to 99% of women had suffered from physical or sexual abuse prior to their use. And what this tells us is it makes it more difficult to quit and avoid relapse. When we think about what's going on for an individual and trying to manage and juggle both things, it's incredibly difficult. And we have to think about that in terms of treatment. We're not just dealing with one bucket, we're dealing with a lot of buckets, or there's a lot of balls in the air of what's going on for that person who's sitting in front of us. So what is going on? What stops women from seeking treatment? We just had astonishing rates of how little people even understand behavioral health needs, understand seeking treatment. And what we know is that rate's even worse for women. And so here are some of the factors that go into women being less likely to actually seek out treatment. There's greater stigma for them. They're supposed to be that rock that holds their family together. They feel like going to receive treatment could actually have them at an increased risk of losing their children. And so we can see why that would deter people from ever walking through the door of a treatment facility if they think that if they admit to this problem, if they are seeking treatment, that they could potentially lose their children, and to them, their family would fall apart. There's a hold it all together for their children, for their families, and so it becomes something that they want to be invisible to an outside society and an outside world. Family roles, we talked about them as mothers, and they actually have a higher rate of poverty. And so when we were just listening to the previous talk about the expense of receiving services, that primarily affects women. So 1 in 7 women in a country lives below the poverty line, which means their ability to seek and to fund services for a prolonged period of time is incredibly small to get the effect that we need to see. So what are some things we can do to help women seek services? We can increase economic support. The previous talk to mine really showed some different areas that we can look at for policy, we can look at for different funding mechanisms, and we can look at to try to support our providers in providing services. Childcare options, as I said, the mother primarily carries the role of caring for their children. And so what they have found is specifically to substance use treatment, if they have on-site childcare, the rate of actually getting women to walk through the door and then also to continue to engage and show up for treatment is it's more than double. So childcare options have to be thought about. The cost of child care has to be something that providers are thinking about when they're thinking of responding to women's needs. Increase intensive outpatient options. Women are less likely to go to inpatient options for fear of their households falling apart, for fear of someone not caring for their children, for fear if I remove myself, the world's going to stop moving, right? My household's going to stop doing having progress, and my kids are going to be impacted by that. And so what that means is that we need more options with very extensive, intensive treatment for women to seek during the day, potentially when their children are at school, but then they're able to return home or to be with their children during the hours their children need care. Screening for mental illness, this is because of the rate of comorbidities. Again, there's multiple balls in the air. There's not just the addiction, the substance use that is going on. And so for women, we need to make sure we're screening depression and anxiety, which we know all occur at higher rates for women, especially on women who are dependent on substances. Exhaustive trauma screening needs to occur, again, just because of the rates alone, specifically sexual trauma and victimization, and specifically with intimate with the women, and we know their history of trauma, and how can we incorporate that to make sure we're doing comprehensive wraparound services. An increased emphasis on avoiding relapse, because that window is so small for women. It is so small. We need to do that early. It doesn't need to come at the end. So again, there needs to be some unique intervention development that also looks at kind of changing the modules or the treatment plan that is going on for women, because our period with them is so small during that time. We can't wait till the end to then talk about relapse. Implementing methods to cope with stress triggers. As I've said, women have unique triggers and stress that are going on. There's unique burdens on the shoulders of women. And so we have to think about those. We need to help them critically think about what are the demands of you managing your children's schedules, of making sure you're showing up and picking up your children, making sure you have food on the table to feed them. And then lastly, relationship management. And this is important because intimate partner violence is pervasive in women who abuse substances. And so we have to think about how are they managing that current relationship with that partner. And even if it's not with that partner, there's typically a historical relationship that might be a trigger for them. And so now I wanted to take this opportunity to highlight some subpopulations when we think of women and we think of their substance use disorder. And as Ellen spoke about, we're doing some unique work in a couple of these areas, as well as I'm sure some people in the audience are also. So pregnant and postnatal women, this is becoming a topic, especially around opioid addiction. We're seeing more children who are born addicted to substances than we have ever before. And so this is a subpopulation that needs increased attention and awareness brought to, because it's not only affecting the women, but it's affecting young children. And what we also know is it's affecting parenting. So we can think of how hard it is parenting a newborn. I'm sure a lot of us have been there ourselves. It's incredibly difficult, but especially for an addicted mother who's all kind of fight that addiction. Also, time that mothers typically step out of receiving treatment, but it's a point of high stress for women. And so that also means high stress means what? Probably increased substance use. And so it's a time where we actually need women involved in treatment, engaging in treatment more and more. I think we can understand why we need to focus to see what can get women in treatment, what treatment is appropriate, and not only helping the mother, but also helping the children that they're caring for. Another subpopulation is the homeless population. So out of homeless families, 2/3 of those are headed by single women with children. So on any given night in our homeless shelters, and when we look at homeless families, 2/3 of those are women with children. Again, this isn't only impacting one person, but what we see is a whole family unit being impacted. And not only a family, but communities are being impacted by this. And so that makes up 21% of the total homeless population. So almost a quarter of our homeless population are single mothers. So again, these women are carrying a burden. They're trying to find a safe place to lay their heads, to have their children lay their heads, but they're also dealing with addiction. And so this is a population that we have a proposal out to SAMHSA currently to look at a pretty comprehensive trauma-based substance use disorder treatment to help address and help women find the support they need to remove themselves from their addiction, but also to have sustainability in their communities. The third population is criminal justice involved women. So incarcerated women in treatment are significantly more likely than incarcerated men to have severe substance abuse histories, co-occurring mental disorders, and high rates of past treatment for both of those things, mental health and substance use disorder. And what we also know is jails are the #1 provider of our behavioral health in this country. And so we really need to look at criminal justice involved populations as a field of social work. We have to look at how do we get more social workers in this environment, because this is where we can actually meet people's behavioral health needs, which we know currently there's a gap. In the prisons here in Florida, 90% of people who need substance use disorder do not receive it before they're released back into their communities. The 10% that are receiving the services, they're not always the appropriate services based on the need. And that's a capacity issue, that's a funding issue. And so as people who want to address this issue and stand up and advocate for populations who have behavioral health needs, we need to look into being in our prisons and jails and how we can use that opportunity to respond to the needs of women specifically, but also men, sorry. And then the rural population, there are unique uses of substances and in the rural population, but what we also know is they're lower on service providers, right? That's not astonishing to anybody. And so when we leave even Leon County, I'm new to Florida, so I apologize, but when we just jump a couple miles outside, we see how drastic of a need there are for service providers to meet those populations. I know some of you sitting here experience that, and you might be service providers in these rural communities. And so the need is high, but it's especially harder to get women and to locate women who might need your services. And so we need to really think about how can we use different methods to reach this population. And so when we think of telemedicine, how does that transfer over to providing substance use disorder treatment to women, especially in rural populations? Where could we have touch points? Are there public libraries to do meetings? And so there's just a critical need to think about how we can deliver better treatment to women who are located in rural populations. All right, that is all I have to share with you today. Thank you so much for your time, and if there's any questions. I think we've got time too.
Are we aware of any overlap between Black justice and are there any notes about that?
Access, are you talking specifically in the rural communities or just in general? I haven't seen anything. That's a really good, I mean, in rural communities and even in telemedicine, that's something that they try to address and overcome. But in general, I don't know. I would love to look into it and follow up with you though. Yeah.
The impact of trauma on women. I mean, there doesn't seem to be that much publicity about, results. This is also sexual abuse, physical, domestic violence is going to. And is there a reason you think there's no linkage, or is a publicity about that?
Publicity in general, I don't think there's enough about it. I don't think we have ever been okay understanding the rates that women are being victimized in our country. And those are staggering numbers when we can admit that 80% of women who have substance use disorder have been sexually victimized. And we have to own that rate. And I think once we can own it, we can better respond to it. But at the same time, as a country, I don't think we've been prepared to kind of have that discussion. that has felt okay.
I think Carol had a question.
Oh,
Yeah,
sorry.
I was just wondering, especially when we think about some of the strict use of substances, in particular for women of color and African American women, because of course in so many of the categories we talked about, there's some disproportionality. there.
100%.
And so I'm wondering if you could just share any insight about some of the research that you found that particularly might highlight the pervasive need for African American women in substance use.
So I don't do specific work with African American population. We're seeing all these gaps increase and the burden become heavier on every single minority population. In terms of unique needs for treatment, I don't think we're even there yet because we don't have it for just women in general. So in terms of treatment and thinking of access issues, I think we can use literature from other fields and try to better understand that. But because we haven't even figured it out for women, based on the literature I've read and that I've been into, we haven't even started to get into the subpopulations. But when you're looking at the rates are increasing at astonishing rates for African American women, for Native American women, for Hispanic women. And so that's alarming. And that's going to show that we need to pay attention. We need to wake up and we need to start figuring it out quicker than we are.
Hugh and then Mimi.
Have you pulled anything out in terms of the LGBTQ population, particularly lesbian women? Because most research shows a higher percentage there as well.
I have not in my work yet. But yes, I've seen literature that supports that 100%, but I have not.
And Mimi?
Some really model programs for mom baby residential treatment, like ARM and several others. But there's this huge disconnect between really treating the trauma, and we know that it exists, of course, where so many parents coming into dependency are losing their children because of their addiction.
Yep.
And when we understand that trauma is the root cause of it, I think it makes people much more sympathetic to the issue, but we still are doing an abysmal job of treating the mom baby dyad. And but what we found with early childhood court is if we treat the trauma and the parent and the child together, then we can have reunification. Moms who've lost 6 and 7 other babies because of their addiction can get clean and we finally, address their trauma. So I'd love to see so much more work involved with trauma and addiction.
Yes, not to speak too much about our SAMHSA grant, but that's exactly what we're trying to look at is that dyadic relationship between the mother and child and how reducing stress with the mother actually reduces stress on the child, which then hopefully impacts their long-term outcomes of engaging in substance use at an earlier age, because what we're seeing is people and women specifically are engaging with substances at an earlier age than they ever have before. And so there is there's new analysis techniques that actually allow you to look at that dyadic relationship and how similar measures for both the parent and the child and how their interaction can impact and change a trajectory long-term. So not only impacting the mother, the child, but that relationship and then long-term outcomes for both. So it's really interesting, and we could not agree more that that's where the field needs to focus.
Okay, thank you, Tanya. Thank you so much. So our next speaker is Angela Chong. She is going to speak with us about some new initiatives here at FSU that are specifically dealing, and find it, early young adults. But I had it up here and I just have to find it. Sorry about this, folks. Yeah, the second one. And I named it even Angela to make sure I knew what I was doing. Okay.
Okay,
Thank you, Angela.
my pleasure.
And I'll give you a 5-minute warning.
Sounds great. Can everyone hear me all right? Okay. So I would like to thank the College of Social Work and all of you for having me here today. I am the Associate Vice President for Student Affairs over Health and Wellness and Dean of Students at Florida State University. And I am just thrilled to be talking about something other than the coronavirus. So, again, thank you. But I also understand that I am the only thing standing between you and lunch. So I will try my best to make this dynamic. This is something I am very, very passionate about. It's hard for me to contain this passion for this work within 15 minutes, but I promised Ellen I would do it. So hopefully I will just exude. You can just pick up the passion, and I won't have to go into a lot of all the depth that I could. So I want to tell you a little story before I jump in. I've been at Florida State University for 18 months. Before coming to Florida State, I was at a place called the College of New Jersey in Ewing, New Jersey. Anyone heard of it? Yeah, my Jersey peeps. Yes. So the state of New Jersey had a governor back in the day named Chris Christie. Some you've heard of him. And regardless of how you feel about recovery. So he and I are friends in that way. And he gave my institution, my former institution, a grant and said, create a collegiate recovery community. That never happens. So we had the opportunity to create a community from scratch. The only mandate was that I provided housing. So I found myself in the rare circumstances that I had all of the money that I needed to create a program. So I bought a house, I hired staff, I created a program, and nobody came. I had no students identifying as being in recovery from alcohol or other drugs that was saying, Angela, sign me up. I want to be a part of this community. I want to embrace the support of my recovery journey. So that was year one. We figured it out. And but my last year at the College of New Jersey, I sat with the families of 8 graduating seniors at a relatively small place. And we had the best time celebrating their students' journey and knowing full well that had it not been for the recovery program, they wouldn't have been where they were that day. So, and I still get emotional thinking about those very special students. So we learned a lot during that journey. And when I landed at Florida State University 18 months ago and realized we did not have a collegiate recovery program, this was one of the very, very first things on my agenda. So I want to buy of higher education right now. Okay. And out of you, do you know if you have a collegiate recovery program? Okay, if you are at Florida State University, raise your hand. We have a collegiate recovery program. Yes. So we're going to talk a little bit more about that. And the Jersey is gone, and I'm saying y'all. So a collegiate recovery program is housed in an institution of higher education that confers degrees. And we embrace an abstinence-based recovery as a standard of the field. So that it's, we typically, as collegiate recovery programs, support students identifying as being in recovery from alcohol or other drugs. Now, there are other recovery programs across the country who are also talking and supporting students in recovery from disordered eating, gambling addiction, and other things. But for the most part, the lion's share is recovery from alcohol and other drugs. Recovery programs have paid, qualified, trained, and ethical and dedicated staff members who provide a bubble, a cushion of support around these students to navigate their recovery. Successful collegiate recovery programs have dedicated space. And when I'm talking about dedicated space, I'm not necessarily talking about having that house that I bought that sat empty before I had to sell it in New Jersey, is that lounges, social areas, gathering areas, areas where they can identify and career journey, whether or not they want folks to know that they're in recovery or not. So a place that provides that buffer where the community can be built, but in a somewhat discreet manner until they're ready to more outwardly identify with that. Provide a variety of recovery support programmatic elements to assist students in maintaining and protecting their recovery. Quite simply, I believe that no student should have to choose between their recovery and Florida State University, right? Because without this support, whether it's Florida State, with football and a thriving fraternity and sorority community and all of these other, collegiate risks, right? No matter where you go, higher education socially outside of the classroom and outside of university sanctioned programming is not always super recovery friendly, is it? Okay. So providing the community, a community of students who offer each other peer support. Back to my story at the College of New Jersey, I had an incredible staff who planned incredible programs. I had an empty house. I had all of these. None of it meant anything if there weren't peers. Because they can get everything else. They can get activities, clinical services. They can get that anywhere outside of our walls if you really truly think about it. What they cannot get is that community piece. So that's the number one element. And often, programs often identify and collaborate with on and off campus partners and stakeholders, connecting with clinicians on those pieces, and their nonprofit entities. None of us are in this to make the money off of our students. Collegiate recovery programs are expensive. But my argument is that it is more expensive not to have it. So we'll talk a little bit more about that. So for our data folks, before I jump into this too, I want everyone to know this number. 4% of students in higher education self-identify as being in recovery from alcohol or other drugs. So if you do the math, Florida State University, I have over 1,600 students identifying as being in recovery that I don't know who they are yet. Okay? These are students who are in our halls, going to our football games, going to a tailgate, trying to make friends, and trying to stay in recovery. Okay? With all of the pressures that are already alive and well in college life. And we also know that 40% of the students that we lose at institutions of higher education note substance use as part of the reason. Okay? So that's where the math, collegiate recovery programs may be expensive, but not compared to the number of students that we risk losing. Okay? This is very interesting. We brought in our representative from the Association of Recovery in Higher Education. He came and spent some time with us in the fall, and he provided us with this information. And I see some, but this is just something I cling on to. This is characteristics of collegiate recovery alumni. So after they leave us, after they've been in an identified collegiate recovery program while in school, 96.6% of them stay actively in recovery. Yeah. And the statistics for folks who are part of other recovery programs, either short-term or long-term, we all know through our work that the percentage is not that high. What is it, between 20 and 30%, depending on the programs? Okay. So we know that students who go through their higher education experience as part of a collegiate recovery program, they fare so much better. The other stats here, a little over 10% average rate of any recurrence of substance use. We talk about recovery in these programs fluidly, meaning that if you have We don't even like to use the word relapse. If you're part of this community and you have an episode we're able to bring you back into the community, that the percentage of students who do experience that is relatively low. It's only 10%, because we can get you back. Almost 90% believe that their collegiate recovery program helped them with academic success. That's why we're all here, right? Over 80% believe that their program prepared them for post-grad recovery, and the numbers don't lie. 80% felt that way, and 96% experienced it. 68% believe their program prepared them for professional life. I'll talk about that. And that co-occurring behavioral health piece that we just heard Tanya talk about, 78%, 78% of them also had these co-occurring pieces. And for time, I'm going to tell you a little bit about what we're doing at Florida State so you can kind of see where this is going. So for a program to be successful, I firmly believe that there are 3 elements. The community piece I talked about, so incredibly important. The clinical support, whether that's support that we have available to our students on campus through our counseling or university health services, or through our referral program if they have higher need than what we can provide, and developmental support. It is not just about clinical support and building the community, but we have scholarships to help our students. Sometimes financially, just being able to afford your books is the reason why some of them decide not to stay. And that's $500, $600 in some cases. Career development training, leadership development training, and wraparound case management. So these are kind of our 3 prongs. And our plan. So for all of my FSU colleagues, we are in year 0 of our plan. And the reason why I called it year 0 and not year 1 is because we're so under the radar right now by design. Because I did not want to create a program with no students in it again. Okay, so year 0 is dedicated to our cultivation phase. So we hired a graduate assistant with the support of the president's office and the provost office, identify students and start building community, and using those same students as focus groups. What kind of collegiate recovery program and community are you looking for at Florida State University? And to start building our infrastructure. Year 1 is going to be dedicated to saying, hey, we have a program, so don't feel bad that you didn't know. I haven't really told anybody yet, okay, because we're in that cultivation piece. So next year, year 1, establishing the program, advertising the program, and advertising the program as, see this group of students, I already have a community for you. No one wants to be the first, right? So we have the community already built. I'm working on identifying space for this community to gather. I'm working on awarding scholarships. We've got a lot of really passionate donors that feel very, very strongly about helping students who are in recovery. Year 2, building the program, then more of an outward identity. We project that at that point in time, the rest of the Florida State community will start seeing the collegiate recovery program pop up in places and identify that's something that Florida State University has, with more campus-wide activities, peer leadership roles, pieces like that. And year 3 is going to be all about sustaining the program. So institutionalizing support and structure where I can, exploring a housing, living learning community, and really bolstering that alumni program too. Because as you can see from our data, the alumni are so important as well. So that is what we've been up to. How am I doing, Ellen? Did I do okay? Couple questions. Okay, so that's what I've got going on. Hi.
So you had mentioned the beginning model.
Yes.
And then you had mentioned a little later about relapse and bringing people back in.
Mhm.
I was wondering practically what that meant. Does that mean that they're in housing and they get kicked out and brought back in? Do they stay in housing? How does
So we don't have housing yet at Florida State. Okay, but I'll tell you how we did it at the College of New Jersey. Is that fair? Okay. So we have expectations for not just students who are part of the housing element of the recovery community, but part of the overall community. And how we identify you as part of the recovery community is you are receiving scholarship to be part of it, okay? Where it's based on abstinence. But if you have a rough night, rough day, our first inkling is not to remove your scholarship, shun you from the community, or remove you from housing. That's completely counterproductive. We do have a phased approach of support and intervention, asking the student to engage in a higher level. I'm sorry, I didn't hear that last part.
Is there any plan to allow students that are receiving medication-assisted treatment into the community?
Oh, gotcha. Yes. So what we are planning on doing at Florida State is having kind of a phased-in approach to membership into the community. So because we work with a lot of students who are trying very hard to get into recovery. They want nothing more than to be in recovery. They're just not quite there yet. And to not give them the support of the community, they might never get there, right? So having kind of a phase one sort of, I don't want to say like new member process like fraternities and sororities do, but have a process where we're bringing folks into the community, offering them support and services, even if they're not 100% there for whatever reason that might be, and helping them get to where they want to be. So yes, they would still be part in.
One more question there in back.
I was curious as to how you were identifying the students that were intentional for the program, and if it does include those who are already seeking services at the FSU counseling.
So they're self-identified, and we have a lot of referrals. So the students that we are working with right now, they come to us as referrals, sometimes through the student conduct process, sometimes University Counseling Center, sometimes from faculty and staff. Parents are a huge one. So self-identification, but we take referrals and reach out anywhere we go from anyone who reaches out to us, and we've had quite a few.
Okay, thank you, Angela.
Thanks.
Just a couple of housekeeping. We do have box lunches available. We'd love you to bring them back in here and network with your colleagues. About 12:20 or so, we're going to come back and hear from Dean Clark. And then we're going to have another presentation on substance use disorder in young adults. So I think a very timely conversation in the afternoon. So please take a break, get your lunches, bring them back in, and we'll start up about 12:20. Thank you.